Hello class and welcome to our presentation. I am Myra and I'm here with
Elizabeth Vazquez and Sabrina Nguyen.
Today we'll be presenting the lack of communication when credentialing healthcare providers at Los Angeles County, University of Southern California, or better known as LAC+USC Medical Center. A little bit about LAC+USC. It was founded in 1878. A 100-bed hospital opened to care for the Los Angeles population. In 1885, LAC affiliated with USC, representing an academic partnership. It is one of the 4 LA County hospitals located in East LA, close to our campus. It is owned and operated by LA County. The historic LAC+USC Medical Building attained damages from the 1994 Northridge earthquake that hit. In 2008, a replacement hospital opened on Marengo Street. A 600-bed hospital opened up to serve the population of the LA County. Now, LAC+USC is a premier teaching hospital through its affiliations with USC and Los Angeles County College of Nursing and Allied Health. It has special units like a burn center, a level 1 trauma center, a level 3 neonatal intensive care unit, and this allows LAC+USC to provide excellent care to its patients. Next. LAC+USC's mission and vision are to provide fully integrated, accessible care and culturally care for one person at a time, and its vision is to be nationally recognized for our superior patient care, medical education, clinical research, and contributions to community health. Many people may be aware of LAC+USC through its remarkable affiliations, but what many people are aware of is the lack of communication, especially when credentialing their healthcare professionals. Poor communication in healthcare. Tarrant states healthcare workers today acknowledge that poor communication is perhaps one of the most prevalent problems in medicine. When there is a lack of communication in healthcare, negative outcomes can occur. For example, medical errors, patient injuries, and of course, delays in credentialing and privileging healthcare providers as well as on the onboarding process. Communication is a key component in the delivery of care, but also between departments at any well-managed healthcare organization. Effective communication is necessary to achieve the HCO's mission statement and goals, but also to be able to deliver prominent care to their patients. Next, at LAC+USC, the lack of communication and organization in credentialing clinical staff members has caused problems in the delivery of care to patients. Before going more in depth with such issues at LAC+USC, let's talk about credentialing and privileging first. According to Youssef and Makubri, credentialing is a process which provides formal accreditation and attainment of competencies which include knowledge, skills, and performance in a defined area of practice at a level that provides confidence that the individual is fit to practice in that area in the context of effective clinical governance and supervision as appropriate to the credentialed level of practice. Credentialing is a complex process because HCOs need to make sure that clinical staff members are meeting the minimum levels of competency and proficiency when providing care to patients. When the HCO takes time with credentialing, it increases their patient safety, but also lowers the risk of legal liability. Next. Okay, now let's talk about credentialing versus privileging. We've gone over credentialing. Privileging is a process where specific scope and content of clinical privileges / patient care services are authorized for a healthcare practitioner. Basically, privileging grants the provider authorization to provide care to patients at that specific HCO. HCOs must first verify credentials before granting privileges to their physicians. Now, for credentialing, it's the process of obtaining, verifying, and assessing the qualifications of a practitioner to provide care or services in an HCO. So that's where the credentialing department or staff must determine and gather all the documents verifying that that practitioner can practice medicine. Next. So now that we've talked about credentialing and privileging, here's a video.
Doctor credentialing is the process by which a third party evaluates the history, qualifications, experience, and ongoing education of a practicing physician or healthcare professional. Credentialing allows insurance companies and patients to ascertain the quality of care they can expect to receive from the doctor in question. It also protects patients by verifying any malpractice claims or disciplinary action that has been taken against the doctor. First, the credentialing agency investigates the physician's education and training. It is essential to ensure the doctor's training is complete and that they are certified to practice medicine in each state where they are licensed. Next, the doctor is evaluated based on their personal and professional background and history. All information is verified through national agencies like the American Board of Medical Specialists. The doctor's residency, licenses, and certifications are then researched and investigated by the credentialing company. Doctor credentialing is used to inspect all aspects of a physician's life, from their personal history to their malpractice insurance. As a practicing physician, it's important to make sure that all areas of your professional life are accessible and accounted for to ensure an accurate vetting process. The process of credentialing is an ongoing, career-long endeavor conducted to ensure transparency and integrity in the medical industry, and to give patients peace of mind about choosing you as their healthcare provider.
As you can see from this picture, you can see that there are many parties involved when credentialing healthcare practitioners. All these parties have to be interconnected to be able to credential all healthcare practitioners whom are applying. As you can see, not only do the credentialing staff have to talk to universities and insurers, but also to government agencies and hospitals and verification services. But then within that, they have to look at board certifications, immunization records, background checks, check their previous work history, and call their reference calls. Next. In privileging and credentialing healthcare providers, it is important to talk about bylaws. The clinical staff collectively establishes mutually acceptable rules and regulations subject to governing board approval. These define the rights to participate in the clinical staff organization and to provide care with the HCO teams, and the obligations to meet ethical standards to ensure quality and economy of care to the patients, and to participate in educational and quality improvement activities. Bylaws, they help set a contract between the clinical staff members and the HCO. The clinical staff members must accept these bylaws in order for them to provide care to patients at that specific HCO. By accepting these bylaws that are part of privileging agreements between the clinical staff members and the HCO. As you can see, bylaws are in a critical point in credentialing because they're rules and regulations that the clinical staff must accept if they want to work at that HCO. Next. As you can see, the credentialing process is not easy, which is why qualified individuals are needed to complete the process in a timely and effective manner, and making sure that the individuals assigned to the credentialing process are organized is critical. Administration staff not experienced nor qualified enough in the credentialing process is a big problem, because then the process will not be able to move forward. It's going to be more timely and it's going to create more problems. By not having proper protocols and procedures when it comes to credentialing, that's another issue. Without proper protocols and procedures, there's not going to be a set list of steps to take and what to do after step 1 or step 2 or step 3. When it comes to having a bad workflow, the documenting of documents would be a lot worse, because the bad workflow will cause more delays in the process and also problems. Finally, with the lack of organization by administrative staff, they might forget to review certain papers or have papers available to the clinical staff applying for credentialing, but also they might forget to remind staff that it's time to re-credential. Next. Okay. These two problems are what are happening at LAC+USC Medical Center. Problem one, the lack of communication along with organization and proper policies and procedures in the privileging process has caused issues in privileging clinical staff members in a timely fashion. Problem two, human resources. The human resource department is handing out badges to physicians without checking if the physician is credentialed. Next. Now, Elizabeth is going to be talking about an interview that she had with an admin staff at LAC+USC.
Hello class, this is Linda Rivas. Linda works for the Department of Surgery, whom is involved with credentialing surgeons and advanced practice practitioners. Linda, would you please give us a quick intro and tell us what your role with credentialing is?
Thank you for having me, Elizabeth. As Elizabeth said, my name is Linda Rivas. I work for the LAC+USC Medical Center. I am the administrator over the Department of General Surgery. I oversee 12 surgical specialty services.
Based on your experience with credentialing, could you give us some areas where you see that there are opportunities for improvement?
So the credentialing privileging process itself is, there are a lot of moving parts. And with that being said, there are also interdepartmental relationships that you have to develop and you have to go and work with closely and collaborate with in order for a provider to be credentialed. So with that being said, that in itself is a challenge. And what we were seeing is that although many departments are onboarding and credentialing and achieving the same goals, the pathway to get there was extremely fragmented. And as you can imagine, if you have 5 departments onboarding a provider, they're doing it 5 different ways. So there was no streamlined, standardized way of achieving the credentialing goal. And things were getting lost in the cracks. There was a lot of overlap of work. There were delays, confusion, depending upon who you were dealing with at whatever given portion of the process. You were given different different responses. So there was a lot of room for improvement, to say the least.
Okay, so was there a process prior to the meetings that you're holding now? Was there some kind of standardization of the process, or was there any kind of to-do list or check-off list that the Department of Surgery or that the credentialing office was using?
No, it was, like I said, it was fragmented and dependent upon the person that you were dealing with or who, or which department you were working with, the process was different. So if I was, say my trauma department was onboarding a provider that was incoming into their area, they would be doing it ABC, and my general surgery admin support that would be doing like a MIS provider or a thoracic provider, they were doing it a different way. Like I said, the end goal was the same, but getting there was, it was dependent upon who was doing the process. So at any given time, if I were to try to find out where my ACS surgeon that's coming in July 1st was, I would ask, and it would be difficult to pinpoint exactly where in the process this person was, which made it difficult moving forward, because the credentialing and privileging portion of bringing a provider on to perform procedures at our hospital is only one component of an actual onboarding and getting a provider in and ready to be able to perform procedures.
So what do you think that creating a standardized process would help do?
Well, it would definitely be more efficient. It would provide for multiple departments to achieve the same goal, but you would have triggers or a timeline that you could rely on. If everybody is doing the process in a standardized way, getting to the end point would be, like I said, more efficient. There would be less overlap, less confusion. Deadlines would not be missed. Simple things would not fall through the crack. And I believe that it would it just makes for a seamless workflow. And if everybody knows what the expectation and the criteria is, then getting to the end point is a lot easier, and following through and picking up also where certain persons left off with respect to where the provider is in the credentialing ongoing process.
Hello, class. This is
Okay, so as Linda mentioned, the lack of standardized process causes issues such as difficult to track where the provider is at in the process. So if you have one person processing the individual A through B, and the next person B, C, D, E, or 1, 2, 3, and then the next person 4, 5, 6, then you can't really tell where you are at when onboarding the provider. There was also issues with loss of documents due to lack of organization. So sometimes they would hand it to one administrator that wasn't assigned to them, but because they're easily accessible, they would hand it to, we'll say, person A, and they'd ask person B about it, and we weren't really sure where the document was at. There are also delays in privileging because of the loss of documents, or sometimes even the providers, without giving them hard deadlines, they would take their time and then rush the documents, trying to submit the documents prior to that 3-month deadline that they have. And that would make it so that there were more rush emergency privileges, which the hospital likes to refrain from. Those problems are also a risk. There's a liability for the hospital if there are any problems with the provider and the surgery, or if there's an audit, they could be fined, or like I said, if there's a problem with the surgery, there could be a lawsuit. Also, if there is a case scheduled where only provider Lee could perform the surgery, and that provider Lee isn't ready and credentialed and onboarded properly by the date of the surgery, then that could cause changes in the OR schedule, causing cancellations. And if there is no other person to fill that spot, that's a loss of money that the hospital is taking on. Some of the solution that we as a group agreed upon was multi-step solution. We thought that if they create a task force to analyze the current process and flag where there are OFIs, that it would be a start. From there, if the teams collaborate to get rid of waste and design or redesign the process, it would help everyone be on the same page. Once the process is set, they could do a pilot to see if what they made, the changes that they made, are actually beneficial to the process. Everyone's on the same page. And then once the process is finalized, after they do their pilot, they could train all staff involved and make sure that everyone understands the process, make sure that it's engraved in their brains, that they understand. If they have any questions, that they're able to discuss them and suggest anything in order to create the transformational culture we've discussed in class. We also believe that creating a checklist of any documents that were submitted or that need to be submitted, and kind of tracking where you're at in the process would benefit everyone. If you create a checklist, like say for example, a spreadsheet that's shared departmentally, which is something that we can now do, you can easily pick up where someone else left off. Since it's standardized, I could start the process and my coworker could pick up if I'm out for a couple of days, and we'd all be able to see where they're at in the process if there's a shared spreadsheet. We agreed that if you meet with all stakeholders and you create a standardized process, it would benefit all parties involved, and that it would help assist in a timely and efficient privileging process, which would then allow adequate deliverance of surgical care. And then this is one of the workflows that we kind of was generated to kind of assign people their tasks. It's color coded, so like the dark grays would be the same person working on those things. The lighter grays So it's easily, it's visually easy to follow, and it's also, it assigns not only hard deadlines or harder deadlines, but also kind of assigns a task to a specific person, where you can, you know, if someone's asking where they're at in the process, you can say, I don't know, we're at step 1 or at step 8, and it'd be easier for everyone to kind of understand how that flow is going.
So the second problem that LAC+USC Medical Center has, like Myra mentioned before, is that the HR department is handing out badges to physicians without checking if the physician is credentialed. So this could lead to a number of problems. Well, for one, HR must retrieve the badges back from the non-credentialed physician. This could lead to physicians practicing without being credentialed, and patients are now receiving treatments and care from these non-credentialed physicians, which ultimately leads to lawsuits. And there was a case mentioned in the article of Credentialing and Privileging, a Primer for Nurse Practitioners, the case of Wellstar Health System versus Green. Now, this case presented negligent credentialing, which involved a nurse practitioner. The nurse practitioner was named Miss Odell. She was a licensed nurse practitioner at Wellstar Health System in Georgia. She was caring for a patient named Miss Green, who started developing symptoms of an ear infection. Unfortunately, Miss Odell's license was expired at the time. However, she felt like she was able to still diagnose Mrs. Green's symptoms. So she decided to diagnose it as an ear infection and discharged her home with an antibiotic. Unfortunately, a day later, Miss Green died due to a heart attack the next morning. Her family did sue Wellstar for negligent credentialing, since Wellstar failed to ensure Miss Odell was a licensed nurse practitioner. The Georgia courts held Wellstar liable for negligent credentialing, which was obviously a viable cause to Mrs. Green's death. Now, the case of Wellstar Health System versus Green exemplifies the consequences if LAC+USC Medical Center did not validate whether a physician was credentialed before handing out their badges. Now, without validating the physician's credentials, it can lead to errors in treatment and legal litigations. Next slide, please. Some solutions that we thought of is, one, creating a drive to ensure that the provider is credentialed, which will be shared between the credentialing team or the committee and HR departments, as well as implementing a checkoff list to ensure all requirements and documentations are met prior to handing out the badges to the providers. Now, by creating a shared drive, it allows the credentialing committee to record whether the physician has been credentialed and will allow the privileges. The HR department is granted access to the drive to verify and confirm whether the physician has been credentialed. In the shared drive, a checklist will be implemented to ensure proof of each documentation, from academic degree to medical training, certification, license, etc. The HR department will confirm with the checklist from the credentialing committee to make sure that the physicians have submitted all their documentation. By following these steps and considering these options, it will help minimize errors and mistakes within LAC+USC Medical Center and lead them into becoming a more substantial, successful, and well-managed HCO.
Okay, class. For a conclusion, we'll White and Griffin, they state, properly run, the credentialing process will not be a prominent element in the HCO operations. A sound monitoring process at the service line level will identify clinical staff who help before the 2-year credentialing review. By having trained staff, great communication, standardization, organization, and a shared drive, it will lead LAC+USC to improve their credentialing process. It is critical to have staff who will support healthcare providers during the process. It is a long and complex process, which the committee needs to make sure that medical providers' education, training, work history, licensure, regulatory compliance records, and medical and malpractice history are evaluated before they treat patients. So by having all these solutions, it will lead them to improve their credentialing process, but also to achieve their mission and goals when they want to provide care to one person at a time. Next slide. Next. Well, thank you guys for your time and for watching our presentation. We are looking forward to answering all your questions, and we will see you in class on Saturday. Thank you.